seminar today. Thank you, William, for starting the recording. Leveraging the expertise of Yale Center for Methods and Implementation in Prevention Science, otherwise known as CMIPS, and Yale Center for Interdisciplinary Research on AIDS, otherwise known as CIRA, READY, the rigorous, rapid, and relevant evidence, adaptation, and implementation to ending the HIV epidemic implementation science hub, quite a mouthful. That's why we call ourselves the READY Hub. We provide technical assistance to 10 ending the HIV epidemic projects in New York, New Jersey, Alabama, California, Florida, Pennsylvania, Georgia, Illinois, and Texas. READY does this in collaboration with the Implementation Science Coordination, Consultation, and Collaboration Initiative, otherwise known as ISCI, creating opportunities to translate local knowledge into generalizable knowledge whenever possible. READY offers comprehensive expertise in implementation science methods, frameworks, strategies, measures, and outcomes in HIV/AIDS research, design and management of experimental and observational implementation science studies, data collection and sampling, quantitative, qualitative, and mixed methods analytic approaches, health economics approaches, partnership formation, community-based participatory research, and public health ethics. And this seminar is a part of our READY Hub seminar series. The event is co-sponsored by CMIPS, CIRA, and ISCI. If you'd like to know more about future READY webinar events, please notify William Tootle, who's on this call, in the chat, and he'll be happy to add you to our email list. So today, we're very excited to have Sten Vermund, Dean of the Yale School of Public Health, Professor of Public Health at the School of Public Health, and Professor of Pediatrics at the School of Medicine. One of my favorite people here at Yale and a wonderful colleague with whom I'm working on many projects. He's going to share some of his 20 or 30 more years of wisdom and experience, in particular on interventional trials in progress in the United States through the HIV Prevention Trials Network. Sten is an infectious disease epidemiologist. His appointment here at the Yale School of Public Health is in the Department of Epidemiology of Microbial Diseases. His research focus is on diseases of low and middle income countries and on health disparities in the United States. He's focused on healthcare access, adolescent reproductive health, and the prevention of HIV transmission, both mother to child and among adolescents and adults. As with so many other public health faculty, his most recent work has focused on the COVID-19 pandemic. Dr. Vermund has founded non-governmental organizations in Zambia, Mozambique, and Nigeria, and he served as the principal investigator of the HIV Prevention Trials Network from 2006 to 2012, and is a member of the National Academy of Medicine. The title of his talk today is Interventional Trials in Progress in the United States through the HIV Prevention Trials Network, from which I think many of us in the READY Hub and in the ISCI Collaborative and some of the offshoot projects that are going on in relation to these, we can learn a lot from this. He'll speak for about 20 minutes, and then we'll open up the floor for discussion where I'll be serving as moderator. So thank you very much, and let's turn this over to Sten.
All right, thanks very much, Donna. I over-prepared, so I may skip some slides. But let me just
take a little bit longer. It's totally fine. We really want to hear from you.
Okay, so let's see there. If this were a history lesson, we might be talking about trials that were done for behavior change, for abstinence, be faithful, and condom use, or control of STDs to prevent HIV, various prevention of mother-to-child transmission strategies, not just ARVs, but also treatment of chorioamnionitis and other approaches, male circumcision, various behavioral economic approaches like contingency management, early studies of treatment as prevention, many, many others. But this is not a history book. This is a current activities talk. So the HIV Prevention Trials Network prefers to have HIV endpoints for its studies of at-risk individuals. Sometimes we can't get to HIV endpoints. We have intermediate studies. We call those Vanguard studies. So there are four big buckets of current activity in the HPTN. One is in the universal test and treat arena, taking treatment as prevention as a basic idea and seeing if you could actually extend it at a population level so that by doing the right thing for HIV infected persons, diagnosing and treating them, you could actually have a community level benefit by reducing transmission to others. Pre-exposure prophylaxis needs no introduction to this group, and broadly neutralizing antibodies to prevent HIV, and I'll explain why we're doing that. And then what we call integrated strategies, or what you might say are multifaceted strategies, bundling approaches together to see what impact you can have. And then my last slide will be just a few notes on how you can access HPTN data. So this study is perhaps familiar to a number of you. We call it the HPTN 071 PopART study. It was a package of interventions, which was termed the full PopART intervention, which was mobilizing communities, promulgating circumcision, recognizing and treating STDs, motivating and facilitating diagnosis of HIV. And Arm A in 21 communities was randomized communities in 2 countries, South Africa and Zambia. Arm A gave antiretrovirals to everybody. Arm C did it as per standard Ministry of Health and PEPFAR approaches. And Arm B did it, expanded to everybody who met a certain criterion. But during the study, the WHO recommended that we should treat everybody. And so Arm B in the middle of the study became a lot like Arm A.
Was it literally the middle?
It was literally in the middle. And this was a very large study which assessed incidence based on population cohorts. And you can guess that randomizing 21 communities into triplets, so 7 communities per arm, where the triplet communities were similar in characteristic. So we didn't randomize a rural area to an urban area. You randomized 3 urban areas or 3 peri-urban areas or 3 rural areas. And you can see the mischief that randomizing such a small number of communities might introduce. You don't necessarily get full comparability. And this is the PopART intervention referral for voluntary medical male circumcision, prevention of mother-child transmission, STI screening, TB screening, condoms, universal door-to-door HIV counseling and testing. And this was provided to arms A and B, but not Arm C. So what did we learn? PopART achieved the first 2 UNAIDS 90/90 targets, namely high rates of testing and high rates of linkage to care. High rates of viral suppression were also achieved. And in a bizarre finding, the group B did better than group A, and was a highly significant finding that we reduced HIV incidence by more than 30%. And in group A to C, we only reduced it by about 7%. And when you merge them, it was somewhere in the 30% range, 20s, in the 20s. So the lack of significant effect in the full arm is still a mystery. Donna and I and colleagues have written about this and speculated about why we think this might be the case. And one of those references is below. We're in the tail end of phylogenetic analyses and qualitative research to see if we can learn more about this. And is it that there were characteristics about the communities that randomization did not equalize? That is a plausible, one of several plausible explanations. The signature study was published by Hayes et al. In New England Journal. The Havler and PopART take a look at other universal test and treat studies, like the search study that UCSF promulgated in Uganda and Kenya, like the Harvard Botswana study, and also a South African study done with French support. And those are interesting comparative papers. Let's move on to PrEP strategies. HPTN 076 was looking at rilpivirine for PrEP in cisgender women, and looking at injections versus placebo injections. It was a fairly small study because it really was a phase 1 kind of study. And this study, during the time that it was being conducted, became of less interest, and I'll tell you why in a minute. Long-acting rilpivirine was found to be safe. Women liked the option of a long-acting injectable for PrEP. And we think that the data were useful for subsequent trials, but despite being well tolerated and acceptable, rilpivirine for PrEP did not move forward to phase 3 trials because there are storage and transportation problems and a very low barrier to resistance. So while we've published these papers, the reality is rilpivirine is not a very promising agent. And this has happened to us before. We've launched entire PrEP studies with agents that in the time of the study became of considerably less interest to the community because more superior drugs became available. That's how fast the HIV field moves, and especially when use of ARTs are involved. And so it's risky to do these prevention studies because you spend a few $1 million, end up with the results of a trial you don't much care about anymore. And you have to squeeze that trial for all the possible data that will be relevant to the overall field, even if the drug is not of interest any longer. We did the same thing with Maraviroc, oral Maraviroc, and during the trial, it became less interesting than other drugs. So here's one that is interesting, or daily oral.
Sorry, Sten, if you don't mind
Sure.
going back, because
Sure.
it's very interesting, when trials stop. And I wonder if you could say something about the process of how these studies, like the one the PrEP example, like usually investigators are very invested in trying to keep their study going at all costs.
Yeah, we decided not to stop the study because the data were emerging as we were completing the study. And there was a point at which we didn't have full confidence that rilpivirine would be of no interest. It just seemed like it was going in that direction.
I see.
And roughly by the time we stopped the study, it was clear that this was not going to be a drug that we carried forward in the future. Mm-hmm. But we have had circumstances where the study has become less interesting in the middle of the study, and you have a very, very tough decision whether you're going to pull the plug on the study or whether the data are important enough, perhaps for other reasons, that you're going to continue it. And I can't say that we have a formula. I think it's very much case-by-case basis. Mm-hmm. It happily doesn't happen that often. Mm-hmm. And we're all familiar with stopping rules for futility. And we deploy those quite routinely in the HPTN because either we want to stop for futility or we want to stop because the benefit of the intervention is so much more substantial than we had realized that it would be perhaps unethical to deny the intervention to the control group. So two good reasons to have ongoing surveillance to provide data for your DSMB, Data Safety Monitoring Board. So moving to strategies to see if oral PrEP can be more effective. As people may know, oral PrEP has really only made a measurable impact in high access populations, populations with high educational levels, high risk, and high access to healthcare. So the quintessential risk subgroup are white gay men in San Francisco, the UK, the Netherlands. We do have evidence at a population level of effectiveness in reducing transmission. Not so much clinical trial evidence, but sort of natural experiment evidence. And we have coverage levels in these communities that are high enough that PrEP is plausibly the driver for declining HIV incidence rates because behavioral indicators haven't changed much. But in Africa, where we have such a greater, we have equal need for PrEP as in high-risk populations in high-income countries, it's been very difficult to get people to take PrEP. There's not a perceived need, and there's an inconvenience factor, and the notion of taking drugs when you feel perfectly fine is not as grounded in many communities as it is, say, in the Yale community, where if you've got asymptomatic hypertension, you may very well want to take an antihypertensive. But there are many populations in the US and overseas in which adherence to drugs when you're not symptomatic is suboptimal. So the HERS study, HPTN 082, was recruiting people into PrEP. If they accepted, they were randomized into enhanced adherence support or standard adherence support. And if they declined, they were given standard of care and they were offered PrEP at subsequent occasions. And there was some in-depth qualitative work done. And the main difference between standard adherence support and enhanced adherence support was drug level feedback counseling. So very commonly, we're told by a client that they're taking the medicine. And then very commonly, we have no drug levels suggesting they're not actually taking the medicine. But there's a strong sort of social response bias for people to say they're taking the medicine. And in this case, drug level feedback counseling provides the drug level to the client, and if it's nil or very low, you can alert the client and help the client with the approach. So there was very high uptake, as with most studies. There was adherence declining significantly over time. And there was, interestingly, no effect of drug level feedback. Those women who perceived themselves to be at risk were more likely to can stay on PrEP, which may not be surprising. I think a real blockbuster was that somehow we recruited the lowest HIV risk young adults and adolescents in all of South Africa because HIV incidence was only 1%. And so there would have been very little opportunity to see an HIV endpoint result in this trial regardless. But even on adherence, there was no effect of drug level impact. So it was somewhat a negative study, but very rich in data, and that was published in PLOS Med last year. let's move to other PrEP, namely injectables. We mentioned rilpivirine, we mentioned oral, and now we're talking about a much more promising drug, cabotegravir, which is an integrase inhibitor that has highly favorable characteristics for PrEP. It's hard to generate drug resistance as used in PrEP. Storage is and transportability is favorable, and monthly dosing is readily is providing bioavailability. So it's got all sorts of advantages, and it's not in widespread use for HIV treatment. So you sort of segregate your PrEP drug from your treatment drug so you don't generate resistance to something that you might have to use if somebody does seroconvert. And here we had a run-in on oral cabotegravir, and then we went to this was a placebo run-in, and then we went to placebo injections, and then because these people got active product, and we didn't want them seroconverting at the tail end and then withdrawing drug, we did oral Truvada. And the results of this, these were in men and transgender women, and our DSMB interrupted this study in record time because the oral Truvada group had 3 times the number of HIV infections than participants getting long-acting cabotegravir. So it was a wildly successful study. It was very exciting, published in the New England Journal of Medicine last year. And US FDA approved cabotegravir for PrEP just a matter of months after the data were presented to them. And ViiV Healthcare is applying for regulatory approval all over the world at the present time. There are also cost-effective analysis here. Our CDC director is the senior author on this paper, and a very interesting ethical article and characterizing the HIV infections in more detail, also published. Now, 084 is just like 083, except that it was in women, in cisgender women. So the design was deliberately similar, where you had a run-in on something that was active, and then you had the placebo cab with oral tablets that were active, and then you had, so it was essentially Truvada, oral Truvada versus injectable cab, and then you had active treatment. So it was a little matured from the 083 study, but roughly similar. And this is also unblinded with superiority results, and the papers are now in press. And I didn't have them handy when I finalized the slides, so I apologize, I can't tell you where they're coming, but in the very near future, you'll see a couple of papers from this study. There was also a qualitative sub-study looking at adherence and retention, identifying barriers, facilitators, potentially modifiable issues, and trying to learn about how women decide whether they would rather have injectable or oral, and their decision-making in that regard. And this was in the sites, Rio, Cape Town, Bangkok, Chicago, and Atlanta, and about 50 participants per site on average. And that's nearly finished now. A second sub-study was of 083, so I'm taking back to the men's study. And that was an open label adolescent sub-study, so a bridging study, just to learn about the extent to which adolescents preferred pills or shots because they experienced both, and then they could choose what they wanted to continue, and learn about drug dosing levels in adolescents, side effects in adolescents, what we sometimes call a bridging study, where you don't actually, sort of like what we're doing for COVID vaccines in children. We're not doing 30,000 child, studies. We're doing bridging studies with hundreds of children rather than tens of thousands. And the purpose of this one, I think I've already told you. Now, it was interesting. We only recruited 9 people in this trial. And at the end of the day, we just said enrollment's done. You know, it was just too expensive. And for some reason, the healthy men who have sex with men in this age group were not interested in this study. And we had very talented adolescent medicine people involved, and very few young men wanted to sign up for this study. It was a lot of trouble. It was a lot of time. It was a lot of effort. Some people don't like needles. Some people don't want to take pills every day. So it was humbling to see, regardless of which, you know, option might be available to you long term, young men didn't want to sign up. Now, the 084 parallel study to 083, now remember, these are the cisgender women, also a bridging study, adolescent study, the so-called LIFT study. And this one has done much better, 55 young women enrolled, which is much closer to what our target was. And so young women seemed more willing to sign up for PrEP than young men. Ironically, in the US, young men are at MSM are at much higher risk than young women are. So it's a lesson learned, and we've got a long way to go before PrEP becomes a vital tool for adolescents. We just don't know what motivates adolescents to take it. Now, there's a series of joint studies. I'm not going to dwell on this because time is short, but these are safety and efficacy of broadly neutralizing monoclonal antibodies. So the short story of a long story is that HPTN didn't have the site capacity to do the kinds of studies that they wanted. They approached HPTN, and we agreed to help them with recruitment of subjects. And
what does HPTN stand for? I wasn't even aware.
HIV Vaccine Trials
Network. Okay.
Run by Larry Corey out of the Hutch in San Francisco. In Seattle. And they've been focused on HIV vaccines exclusively, without too much success to date. And they're trying to use passive protection with these monoclonal antibodies that have neutralizing capacity across various viral subtypes, and so-called clades. And in theory, if we can figure out vaccines that mimic these broadly neutralizing antibodies, maybe we'll actually have a vaccine. So it's a really great way to see if the passive administration of these antibodies actually protects people. You could say, why is HPTN doing this when it doesn't have much practical real-world application? It doesn't seem to be a practical way to give at-risk people injections of antibodies to protect them from HIV. But it is a huge contribution to the vaccine world, and we want to help vaccine development, so we were deeply engaged. And a surprise was that a lot of people signed up for this study and were willing to get the injections and were willing to participate, but we did not see significant HIV reduction. So these monoclonal antibodies may not be the ones that we want to try to develop vaccines to generate, because in their passive use, they were not successful. Still, it was such a unique study that it was published in New England Journal, and here are some other studies that are relevant. And I've sent these slides to William and Donna, and anyone is happy to use them. These are not proprietary. If you ever needed to share the results of any of these studies for whatever reason, you could use these slides. Now, integrated strategies. This is where I come in. I'm very interested in integrated strategies. I'm not the big PrEP guru. I don't know that I'm going to contribute much to a passive antibody or active vaccine agenda in HIV, but I'm passionate about integrated strategies. So this is one of them, the HPTN 091. And this is targeting a small subset of the population, but persons who are at especially high risk, perhaps even the highest risk of HIV acquisition, namely transgender women. And this is a study in the Americas in which there was an immediate intervention arm providing PrEP, co-locating gender-affirming hormone therapy services, and peer navigation. PrEP and linkage to care was in the control group, and then 6 months later they were offered everything because it was deemed perhaps unethical to deny them gender-affirming hormone therapy and peer navigation. On the other hand, we wanted to learn is if it would make any difference. So this was almost borrowed from the male circumcision studies, if you remember those designs. And if you don't, you can ask me later. We've recruited 310 transgender women in the US and Brazil, and we're still recruiting. But this study is going reasonably well, and this is one of the largest studies of transgender women for HIV prevention that's ever been done. Then we have HPTN 094, which is a mobile van to provide integrated care and addiction care to injection drug users. And it was the mobile unit versus referral to a sort of a conventional program, and then evaluation. And this study is in a lot of trouble because the numbers of persons signing up for the study is small, and the number of persons using van services is higher, but for ethical reasons, we do offer some services in the van, even if you don't sign up for the study. And there's interest in the van, there's no interest in the study. So I'm not sure what the future is. We've recently made some friendly redesigns to what user-friendly, or you might say client-friendly redesign. So stay tuned as to whether we can salvage the study. It's quite an interesting study, but it could generate a new model for mobile services for drug users, which have been successful right here in New Haven for a needle exchange and many other venues. So giving more comprehensive services was thought to be something that might work. But anyway, it's in trouble. Then we have HPTN 096. This is a very interesting study. It starts to blend into our implementation science network, I think. It is focused on Black MSM in the southeast of the United States. It's community randomized. The intervention arm has a so-called integrated strategy, health equity promotion, social media influencers, intersectional stigma reduction at healthcare facilities, peer support, versus a standard care arm, and looking at viral suppression and prevalence of PrEP uptake. Viral suppression for persons living with HIV and prevalence of PrEP uptake for persons who are not HIV infected. And it's a long 5-year study. And these are the study communities, which were randomized. They were paired based on similarity of characteristics into a couple of groups, and then they were randomized within the pairs to try to capture like with like. And so you can see how Dallas and Houston might be compared, or Montgomery and Greenville, and New Orleans and Fort Lauderdale. So that's what emerged. Now we do have DC and Maryland suburbs, so we're sort of on the edge of not being on the southeast. All adolescent Black MSM living in these communities are eligible, and it's all based on self-report. And this is a very large pilot study. We were not given the resources to do a definitive study, so this is a very large pilot study, and it really has elements of implementation science, but it's a pretty expensive intervention. So this is the kind of thing that if it worked and it got deployed and rolled out, we would take it over. You might think of it that way. This is my last slide, in which all trials data are available after 2 years of database closure. You can sometimes negotiate earlier access. Ashley, Don, and I were somewhat unsuccessful doing that a few years back, but there's a lot of pressure for HPTN to be more forthcoming. And if you actually wanted to read what the protocols are, I've given you the manual of operations links. They're online and readily and open access. So accessing data and public use data. And they do have a number of public use databases that have been developed and are available. So there are troves of these kinds of data, over 60 studies, many signature clinical trials in HIV prevention, things that work like 052, and things that haven't worked. There are other smaller vanguard studies that are of some interest. And I wanted to thank Nirupama Sista, who's the scientific director of HPTN working at FHI 360, for helping me pull all these slides together. So that's it. How did I do on time? Let me stop sharing.
You did great. I mean, we have a good 20 minutes.
Okay, well,
I
I somehow didn't get the memo that I was supposed to only go 20 minutes. I could have cut
totally
out the
fine.
app slides and others, but.
So yeah, so that was a really interesting talk and a really nice overview of HPTN and some of its recent accomplishments in this area. And
Let me also mention that we have an HPTN Scholars Program where if we identify a scholar from an underrepresented minority background and we identify a research question from a secondary data analysis, we can actually secure funding for partial supportive salary, and we can secure assistance from the network for that minority scholar to do a secondary data analysis within the network. It also gets them involved in the network, and a number of former HPTN scholars, including our own LaRon Nelson here at Yale, have subsequently go on to being protocol chairs of new protocols. And this is the purpose that I had when I started this about a decade ago, is I was looking around the table of leaders at the HPTN, and there were very many white faces and many fewer persons of color. And given the evolution of the epidemic and the need to attend to minority communities in the US and international communities, we realized we had to do something concrete to nurture leadership within the network. And I'm happy to say it's working. So keep that in mind, because it may be applicable to somebody on this phone call, and anybody can call me. I still run this program now with 3 of my colleagues, Daryl Wheeler, and Quraish Abdul Karim and David Sirwada. So we have both a domestic and an international scholars opportunity.
yeah, great. That's good to know about. We definitely will keep it in mind. So does somebody, I of course always have lots of questions, but to give other people a turn, or are there others who would want to jump in or raise their hand? And maybe I'll start and then other people will be a little less shy. So Sten, one thing I'm very interested in is, how does HPTN decide what projects it's gonna put forward? And then what funds these projects?
Okay, great questions. We solicit concepts and review them twice a year. So any investigator within the network or outside the network can submit a concept that is reviewed by HPTN leadership. When Quraish Abdul Karim and I were the directors of the network, we were quite democratic, small d, and had a very engaged executive committee. The current leadership is a little less democratic, and they make many decisions.
Can you say what you mean by democratic?
Well, we would have the concepts presented, reviewed by the executive committee, and then discussed almost like a study section.
Mhm.
Current leadership throws out a lot of the concepts before it even gets to the executive committee.
Mhm.
And I'm not saying they're making good or bad decisions, but that's what they're doing. So um, if someone has, now there are a number of favorable elements. If you need multiple sites, that's a tick box in your favor. If you have HIV endpoints, that's a tick box in your favor. And if your intervention is potentially realistic and could be brought to scale, that's another tick box in your favor. If you only need to do this at a single site, forget it. Write an R01. If you have something that's very pie in the sky and is so expensive that it's very unlikely to be replicable after the trial is done, that won't be in your favor. Although you might say, what about those broadly broadly neutralizing antibody trials? That's not practical. But that's done for a different purpose, to inform the vaccine research agenda as well. And then if you don't have an HIV endpoint, your Vanguard study, as we sometimes call it, should at least be able to signpost going to a trial that has an HIV endpoint. Because to be honest, you can't determine if something's going to prevent HIV without studying HIV. So that's how, and who funds it tends to be a real effort. When I was trying to get HPTN 071 PopART off the ground, I went to PEPFAR, I went to Gates Foundation, I went to multiple institutes at the NIH, and ended up patchwork quilting PEPFAR money with Gates money with network money, because it was a very expensive study. And sometimes NIDA takes a lead, as they did with that VAN study, or NIMH takes the lead, as they did with the adolescent oral PrEP study. But often NIAID takes the lead, as with the cabotegravir trials. Those are the three participating networks.
So do these proposals have to have a credible source of funding to be considered for approval?
No.
Or do you first get approved, then you look for funding?
Yeah, it's a really exciting idea, and we, network leadership, can try to help you sell it to a funder. Now, another thing we've done, and I'm glad I thought of this, is that we've had at least 2 major R01s that came to us after the fact. And for example, Audrey Pettifor at UNC got an R01 to use contingency management in adolescents in Agincourt, South Africa, in the northeast corner of the country. And she was going to look at STI endpoints. To study HIV endpoints was going to cost a lot more, and she was going to have to increase her sample size a lot. But she took her R01, wrote us a proposal, and we got it funded by the NIH, and that became a study that looked both at STI endpoints and HIV endpoints in a much larger study. And NIMH paid for most of that, and they had an easier sell to NIH leadership that it had gone through peer review. Similarly, Connie Kellum, a number of years ago, studying whether or not suppression of HSV with acyclovir would remove a risk factor for HIV transmission and reduce HIV acquisition. And she had an R01 to do that, but it was woefully underpowered, and it didn't have the bells and whistles that would be informative if the trial were negative, to know why it was negative, and also some of the elements that if it were positive, to have some insight there. So she was able to round out her study, and we ended up breaking that study in 2, one with an acquisition sort of focus, and the other one was a transmission focus. And she got one funded by the Gates Foundation, the other one we funded. I see Rachel with her hand up, and also Debbie.
Yeah, so let's start with Rachel, then go on to Debbie.
Hi, Dean Vermund. Thanks for a great talk. It's great to see you. I think there you can see me now. Yeah, I'm just wondering, like, if any of these studies assessed fidelity during the trial, especially like adherence to PrEP and that kind of stuff, since that could, potentially impact the trial outcome.
We've learned that lesson over a decade ago, and we gather adherence data with state-of-the-art strategies. And sure, we ask people, but there's also pill counts, and there is blood level evaluation. So the answer is yes, yes, and yes in a big way. Because, and I'm glad you asked the question because it may not be obvious to everybody. Let's say that I do a trial of randomizing to use a novel drug to treat Alzheimer's disease, okay? That'd be a pretty important trial, wouldn't it be? I mean, my goodness. And then adherence to taking the medicine is exceedingly low. So do I present the data to the FDA and say the drug didn't work? Nobody took the drug. So how can I say one way or the other whether the drug worked? So this is the real problem, is that we know that PrEP works in people who take it because we've done the subgroup analyses in microbicide trials, in oral PrEP trials, and taking away volitionality and adherence with injections is a big advantage of PrEP because now you are giving injections and people don't have to remember anything. And we never want to be able to say something didn't work simply because deployment was suboptimal. So that's where measuring adherence becomes all important in a clinical trial such as a PrEP trial.
Yeah, that totally makes sense. I wonder if any of the work has focused on fidelity, kind of in terms of what healthcare workers are doing, who are supposed to be enrolling people based on certain criteria, and like providing integrated services like the VAN program you talked about. Is there any measure of fidelity?
Yeah, let me use 082 as an example. 082 was the oral daily PrEP as in young women and adolescents in South Africa, the so-called HERS study led by Connie Kellum. And that one got 95% of these young women to initiate PrEP, which I've never heard of any PrEP study in young women in Africa to get anywhere near 95% agreement. But there was a very rapid fall off. And many of the young women were not using it at 3 months and even fewer at 6 months. So the qualitative work in that study is trying to unearth what was unattractive about daily pill taking in these young women. What was so challenging for them to stay on? Did they not perceive themselves at risk? Did they simply forget all the time? Did the drugs make them feel sick? Was it embarrassing to take the drugs, and family members, it was easier just not to take them because family members might find them or whatever? And all of that's being unearthed at the present time because the study was a disappointment. The enhanced adherence arm with the feedback of what drug levels are did not improve adherence in that arm, which was a bit of a surprise, to be honest. Debbie.
Thank you. It's just been fascinating to hear about all of this work. So can you step back just a little bit? And you know that there's work going into multi-site implementation studies and a network around that. What are some of the lessons, the more generalizable lessons you might draw, not about particular studies, but about even the act of doing multi-site studies?
Well, there is a lot to be learned from studies of this magnitude, and we've done a better job in the HPTN in recent years getting our community partners, people helping us with community advisory boards, and some of our actual community mobilization teams to actually write about their experience. And so there is a literature from the HPTN that looks at things that worked, things that didn't work in community mobilization and engagement. Some of them may seem obvious. For example, our early PMTCT studies did better with male engagement than they did when we didn't talk to the men, because a lot of women would turn down interventional opportunities based on fear of their husbands and what their husbands were going to say. And so when you took that fear factor away, women were willing to get tested and follow up their status and follow up their baby status. That's just one of dozens of examples that I could give. Some of them are very intuitive, like the need to get buy-in from community leaders at many levels, religious leaders, political leaders, tribal leaders. In the US, it might be community-based organizations, local community leaders, school teachers, ministers, whatever. And others of them are a little more obscure, and that's what we're trying to unearth with our parallel writing about the trials themselves. For example, in 071, we discovered that just shifting the hour by 2 hours, instead of going sort of 9 to 5, going 11 to 7, massively increased our yield for men. Not for women, for men, because we were catching them after work. And we also improved with weekend hours because they were home. So, things like that. Ashley, you get the last question.
Oh, thanks. Thanks for a great talk. I was actually just wanted to ask you about some of those PrEP studies that were presented, and you may not know offhand, but as you know, I'm very interested in spillover, spillover of PrEP specifically, and if any of those trials might have the information to evaluate that. And then the follow-up question would be like, for studies moving forward, if there's anybody interested in designing studies to assess spillover PrEP. So like we've done with vaccines, we can inform coverage levels needed to reduce HIV transmission.
The nature of the data that you might be looking for spillover, I do not believe is well represented in these PrEP studies. However, you and I should talk offline because I can research this more thoroughly and even get one of the principal investigators on the phone, and we can, or one of the clinical officer, one of the clinical managers at FHI 360. These people know these studies like the back of their hand, and we could have an intelligent conversation with them before we jump to conclusions that it couldn't be done. Look what happened with the study that you've been using from the HPTN. When we started out, it wasn't obvious that those data would be as helpful in the spillover data as it's proven to be. And now you've got a couple of flagship papers out of it, which I think is just incredible. Now, in terms of going forward, HPTN is always keen to have fresh new ideas for improved science. The push and pull there is that some of these trials are made so complicated because it's science by committee. So trying to satisfy everybody, it makes them too complicated and it makes them too expensive. And the complicated side, we get a lot of pushback from the field managers and the folks in the field who are supposed to operationalize this. And the too expensive, you get the pushback from the NIH, who's expected to cover these high costs. And so what is really effective is if you get wind of a trial that's emerging and you write your own grant to support an add-on study. And I would think that if I go to an NIH study section and I have the whole weight of the HPTN and I've got a $5 million, $10 million trial backing up my measly little $350,000 R01, that I would have a heck of a lot better chance of getting that R1 than if I didn't have HPTN. So I think that that is another way to angle it, is to say, what data do I need from communities or from partners, sexual partners, needle use sharing? What data would I need, and how affordably can I secure this? And can I set up my own infrastructure linked to the HPT infrastructure, but that I have a little control over it, and I'm not a burden on the principal trial? That kind of thing has been done by a couple of investigators very successfully. And on that note, I think our time is up.
Well, almost. We have 1 minute, but probably it's better than starting another question, even though I have one.
Go ahead. Go ahead.
Really?
Slip it in.
All right. Well, what I was wondering was this question of like policies changing while these kind of long trials go on.
What a mess.
And
Okay,
so we might be in that situation with PrEP again, even.
Yes.
So I'm just wondering what your thoughts are
Yeah.
after having been in the trenches on this for so many years.
Oh my God. I actually give a lecture comparing and contrasting. I haven't given it in 5 years. I haven't given it at Yale, but I gave a lecture periodically when I was at Vanderbilt on this exact subject. And the difference between clinical trials for treatment and clinical trials for prevention. And without giving you an hour lecture in 30 seconds, I'll just tell you that the risk, I'll use a non-HIV example, the Mr. Fit study, multi-risk factor intervention trial, done in the 80s and 90s. I think it was 330,000 men around the United States enrolled into this massive prevention study. So what happened in the 1980s? You had this fitness craze. Everybody was joining health clubs. People were, the Wall Street Reagan era. You wanted to live forever. And the field of preventive cardiology was practically invented in that decade. And you ended up with all these interventions to control hypertension, control lipids, increase exercise, obesity reduction, etc. And the control group kept creeping up to being very similar to the intervention group. And most of the endpoints of the Mr. Fit study were no difference between the two groups. And that doesn't mean that these things don't work. It just means that the counterfactual went away. And this is a recurring problem in prevention clinical trials, whether it's cardiology or HIV, is they take longer to run because instead of treating a disease where you can get some kind of biological marker endpoint or perhaps even a clinical endpoint in 6 months, you're looking at studies that are lasting 3 years, and sometimes they should last even longer to get the impression. You're looking at an HIV seroconversion rate that might be quite modest. And so there's all sorts of background community mischief that can essentially be a bias towards the null. And you got bias towards the null and you have a negative study. What are you going to say?
I know.
So I do not have a magic wand on this one, other than improving the rapidity with which you launch the studies and trying your very level best to anticipate where the field goes so you don't walk right into a changing standard of care that's going to severely disrupt your study. It's not easy, and some very smart people have not done very well in this, and I'm not sure I would include myself in the very smart people, but I would include myself in the having not done very well, because there were a number of studies in the HPTN that really didn't answer the question that they were seeking to answer, because their counterfactual ended up being a factual.
Great. Okay, well.
Okay. No magic wand. Thank you.
Wonderful talk.
Talk to you
Pleasure
soon.
hearing all of this. Thanks everybody
Pleasure.
for joining us. Bye-bye.
Aye.